So Dr. Scott Selick is an MD, PhD trained neurobiologist and former head of biochemistry and molecular biology at Penn State. Prior to taking a position at Penn State, he was the director of the Developmental Biology Center at the University of Minnesota and recipient of the Martin Lance Harrison Chair in Pediatrics and Cell and Developmental Biology. His research has encompassed the genetics of autism spectrum disorder, tuberous sclerosis complex, and more recently, the regulation of autophagy and cell repair pathways into neurodegenerative disease. Current work examines mechanisms of activating cell repair as a means of suppressing cell loss across the major neurodegenerative disorders, including Alzheimer's, Parkinson's, and amyotrophic lateral sclerosis. He's using structural biology and cell biology approaches to identify small molecule inhibitors of key autophagy regulators that could permit neuron survival and disease suppression. Dr. Selick, please.
Oh, yes. Well, thank you, Camelia, and thank you to your efforts and all those in the HUC who are helping us get together, know one another, and collaborate and go after this disease from Penn State. I'm so happy that we're doing so. So I'm going to, in 15 minutes, try and give you a brief but hopefully useful overview to you of where our understanding of the disease is and what the future looks like. And I have to say, I'm actually really optimistic about the future. There's a lot of incredible findings being reported, and I'm going to give you some of those today, but I think we have a lot to be hopeful for. All right, so I'm going to, let me see. For some reason, I can't advance this. Let me try this way. Oh, there we go. So, of course, we've known about the pathology of this disorder for a long time. In fact, it was Alois Alzheimer who described the 3 primary pathologies that the disease is characterized by. These deposits of extracellular protein called amyloid deposits, these strange misformed microtubule structures inside of neurons called neurofibrillary tangles, which we now know are composed largely of a phosphorylated tau, a microtubule binding protein. And then finally, the accumulation of lipid in what we now know to be microglia. At the time, Alzheimer didn't know what the cell type was, but he noted those accumulations. And this pathology has really driven our attempts at intervention, which is both good and bad, because of course, pathology that you see at the endpoint of disease is not necessarily the pathological mechanisms. It's telling you what happens in the end. But, and I'll speak more to that as we go along a little bit. But anyway, we've known about the fundamental changes for over 100 years. I think the next major event in the history of this disorder was studies by an MD at the University of California, San Diego named Robert Katzman. And at the time that Robert was doing all this pathology out there in San Diego, Alzheimer's was considered to be a very rare disorder. And what Robert discovered was that as he looked at the pathology, a lot of patients, this pathology described by Alois Alzheimer was really quite prevalent. And so he wrote this editorial in 1976 that said, this disease is out there in a far greater numbers than we had thought, and it is deserving of our research and government support, which that was really where NIH began to really invest in trying to understand this disorder. Now, you can't talk about Alzheimer's, of course, unless you really talk about the amyloid hypothesis. And that hypothesis, of course, originated in the pathology that has been known to characterize this disorder. And as we began to understand it more molecularly, we came to understand that those deposits of protein aggregates were largely made of smaller peptides generated from a larger precursor called amyloid protein precursor, APP, or amyloid precursor protein rather. And it gets cut into small fragments, they aggregate, and they form these amyloid aggregates outside of cells. And for that reason, as well as some other genetic findings, the hypothesis became those aggregates are causative. And if they're causative, removing them should arrest the disease. Those are really the essential tenets of this hypothesis. Those accumulations are causative, and therefore we should strive to get rid of them, and that should arrest the disease. Now, this hypothesis, which has really dominated the field for some time, is now really being questioned, largely because reducing the amyloid peptides does not actually arrest the disease. At best, it's having a very modest effect on slowing the disease, but not arresting it and allowing these individuals to, live a normal life. So let me give you some of the data that supports that. So this is a table of 3 different antibody molecules that are being used and succeeded in getting FDA approval to treat. And what I want to point out is this simple thing. So here is lecanemab. That's now got FDA approval, and it's being used in the clinic. It's really effective in getting rid of that amyloid. 81%. After 18 months of treatment, 81% decrease in the amount of amyloid in those patients. That's pretty good. So the antibody is doing what it was designed to do. And likewise for donanemab, the second one, 68% is cleared at the 18-month mark. So those molecules are doing what they were designed pharmaceutically to do. Unfortunately, they're only slowing the rate of decline. They're not arresting it. They're not preventing it. They're slowing it. And at levels that, frankly, most family members would not note if they were observing their family members get this treatment. So that's, in other words, what we thought was the pathogenic mechanism. When we fix it with an antibody molecule, we don't significantly fix the disease. That's an unfortunate disconnect. Of course, the pathology, we've learned a lot more about the pathology since the time of Katzmann. And we now know, for example, that there are abnormalities in many other cell types, not just neurons, but the microglia, which are the immune cell of the brain. It is changed in this disorder. In fact, we know even the molecular signatures of these microglia that are found exclusively in the brains of these patients. We also know that the blood-brain barrier is disrupted. There are changes in the inflammatory response. And if we look in the neurons themselves that are failing, it's not just the microtubules that are strange, but they have problems with mitochondrial function as well. And on top of that, they have membrane trafficking problems that are essential for clearing damaged mitochondria, protein aggregates. So they have a lot of other things besides that overt pathology that was described in 1906 by Alzheimer. The other thing we know is that there are a lot of other contributing factors that are important to consider mechanistically. So, for example, altered glucose metabolism is very prevalent in these patients, and it's actually a more accurate predictor of dementia than either the 2 main markers we consider, which is amyloid or tau. So changes in how glucose is being metabolized is a better predictor. And associated with those changes in glucose metabolism, we know that there are a lot of risk factors affiliated with that, namely type 2 diabetes. It's a big risk factor. Obesity, it's a risk factor. Women have more prevalence of this disease than men. We don't fully understand that either, but it's like twice as many. It's an important risk. And of course, we also know about genetic variants that contribute to susceptibility to Alzheimer's, including ApoE, which is, of course, a lipid binding protein, which also speaks to, oh yeah, this is a disorder of lipid accumulation and lipid metabolism. And of course, glucose and lipid metabolism, they're inexorably linked, right? They are not disconnected. So we've learned a lot more. And this is actually quite good news, because if those are risk factors, we can do a lot to address those and presumably and hopefully decrease the prevalence. And in the last 2 years, this has been shown to be true. The good news is, I think, of the last 2 years of work is that we can intervene in treating the type 2 diabetes, treating obesity, dealing with modulations of ApoE function, and we can actually do something to reduce the risk and severity of this disorder without any formal amyloid or tau-directed pharmacology, for example. So in my mind, that's all really good news. So I'm just going to touch on a few studies that exemplify what I've been saying, that there's a lot of interesting work coming out in very rapid succession about how lipid metabolism is part of this disorder. Their role in microglial function is part of this disorder. This is a paper that has is from Michael Haney, is the first author. He's now a assistant professor at University of Pennsylvania, someone we should definitely have out here to come tell us about his recent work. This is one of the papers that established that lipid accumulation is also predictive for the severity of the disease. So we're beginning to get that as an important marker for the disorder as well. So let me try and connect a few of these things. So I've told you about mitochondrial problems. I've told you about lipid accumulation problems. One of the things that links those events in cell biology is autophagy. And literally, autophagy means self-eating. It's a stress response that's activated when cells are nutrient deprived, for example. And it's literally the formation of a double membrane structure that then can clean up the garbage. It can identify damaged mitochondria and send them to the lysosome, right? In other words, dispose of these damaged organelles and replace them, in the replacement of them with new ones. And of course, mitochondria, they have a certain half-life in cells. They get damaged by the very nature of what they do, which is move a lot of electrons around and generate ATP. So autophagy is critical for cells to be able to remove the damaged mitochondria, prevent the accumulation of reactive oxygen species, et cetera. It's also central to liberating lipids from intracellular lipid stores. It's called lipophagy, not autophagy, but lipophagy. So it's critical for releasing the lipid stores in cells so they can actually import those fatty acids into mitochondria and metabolize them. That's how you get ATP out of those lipids, right? It has to be transported into the mitochondria, beta oxidation takes place, and you get energy from it. So if you have a deficit in autophagy, this membrane trafficking cell repair system, you are going to have problems in lipid storage. It's going to go up, and you are going to have problems in mitochondria because you don't have the mechanism of getting rid of the damaged ones. And damage always happens. Just by doing what they do, there's going to be a certain amount of damage and replacement that has to take place. Okay, so the other thing I want to point out with regard to this hypothesis, the amyloid hypothesis, is really important to bear in mind, is how many people have amyloid that you can detect, either by marker or by PET scanning or whatever method, and how many of those people are cognitively normal? Well, this is a distribution by different age. In the 60 to 69 age group, it's 10, 15%. It climbs to 20 to 25% in the 70 to 79 group, and even higher in the 80-plus-year-olds. Now, in the world of Alzheimer's, those people are called preclinical Alzheimer's. The very name suggests if they have it, they're getting the disease, right? But as it turns out, that's not true. For example, if you look at that group of people in the 60s, 69, what percentage of them in the next 10 years actually develop mild cognitive impairment? It's about 30 to 40%. So the majority do not convert in that 10-year window to having cognitive impairment. Now, that number, it's still higher than if you looked at patients that had no amyloid and you asked what percentage of them in that age group showed mild cognitive impairment during a 10-year window. It's higher. So there's an association, no doubt about it, 2 to 3-fold higher if they have amyloid already at the time of investigation. So there's a connection, there's an association, but the rule or the logic on causation is a different matter. And of course, as you can see, in the 80-plus-year-olds, if they show amyloid, are you going to put them on an antibody drug that might be a bit risky and has side effects? That's, So anyway, I don't think we should be calling them preclinical Alzheimer's. I think we should be calling them, they have amyloid deposit. We don't know what's going to happen to them, but let's do what we can for them. All right. So let me tell you a little bit about the order of events for the FDA approval of these molecules. And this is relatively new. The first FDA approved medication that was actually targeted to improve the outcome of these patients was an antibody molecule directed against A beta in 2021. And it came from Biogen, and it was actually FDA approved despite a panel of experts saying, don't do it. Why did they say don't do it? Because it showed no clear clinical benefit. But FDA did it anyway. They approved it anyway. And it was pretty expensive. But Medicare said, we're not covering it. We are not covering it. And guess what happened? Nobody bought it because everyone was relying on Medicare, right? These are elderly patients who get it. And so what happened? Biogen stopped production in 2024. It didn't survive the market because A, it didn't work, and B, the customers knew it didn't work, and they decided not to order it for their patients. Now, these other two drugs, they also directed against that pathology. And the good news is they do show some slowing of cognitive impairment in these patients. It's around 27% slowing using these cognitive measures. That is not a huge amount, I can tell you. It's probably not what family members would notice, but it's measurable and it's real. Now, there's also a fairly high rate of adverse side effects with these molecules. There's intracranial bleeding at 17%, and there's also edema or swelling of the brain. So those adverse effects mean there's some people that you just don't want to give it to, giving their other medical conditions. And in fact, if you take the patients that have a diagnosis of Alzheimer's and you say, all right, which one of you are eligible for these medications? It's only 8%. 8% of the total are actually approved to take these molecules because of those side effects and what that means in terms of inclusion. So these are just the facts about those molecules. In short, they are not going to solve this problem. Do they help a little bit? Yes. For some patients, is that great? Yes. It is not going to solve this disorder. I also wanted to highlight a couple things again on this idea of how important metabolic regulation is in these. This is a paper from some of the folks we know. This was published in Science a year ago, I guess. Melanie McReynolds, one of our faculty here and our colleagues, was a co-author of this paper, as was a gentleman named Eric Ulian, who's one of my collaborators out at UCSF. This was a lovely, lovely paper in Science that merely had a simple conclusion. You can restore hippocampal glucose metabolism, and it rescues cognition in a number of different assays for pathology in mouse models of Alzheimer's. Really powerful study. So what's the current landscape given all this? Well, those two antibody molecules that I told you, they're approved for use here in the United States, and the European Union just approved them as well. They initially were not willing to do so, but they reversed that initial block of their approval. In the United Kingdom, the National Health Service has said, nope, we're not going to spend that money. What else is happening? Well, there's some very interesting things going on in the world of these GLP-1 receptor agonists. There is retrospective studies that show the incidence of Alzheimer's is lower in those patients who've received 3 years of GLP-1 receptor agonists. I mean, it's pretty significant. It's retrospective study. It's not prospective, with all the reservations that one have to be considering, but it's hopeful. And the prospective study is closing. After 3 years of study, they're closing it to evaluate the data this month. So that means pretty soon we're going to find out in a prospective study, does that metabolic intervention, if you will, do something? The other thing that's been really exciting of late is the evidence that dietary intervention, which of course influences metabolism, does that have an effect? And I was particularly encouraged by this study because it was directed at people who have that high risk because of that ApoE variant called ApoE4. They have a 15 to 20-fold higher risk of getting Alzheimer's than someone that has another allele. And in those people, being on a diet suppress the incidence of new Alzheimer's by about 30%. That's a pretty big number. That paper just came out a few weeks ago in Nature Medicine. I really encourage you to read it. It's very hopeful. And it says that considering how the importance of metabolism, that we can actually intervene for these patients in something that is, I would say, as simple as, but as we all know, getting people to follow diets is not always simple, but it is, there's very good evidence that it works and we should be doing it. So, as you all know, this is a very complicated disease, and sometimes it's really easy to get lost in the weeds because of all the phenomenology, all the different things that are disrupted in people's lives and in their cell biology and in their physiology and neuroscience. But I want to emphasize that there is evidence that the pathology is based on common problems, not just for Alzheimer's, but for other disorders as well. And that is this cell repair process that I've mentioned already, this ability to remove damaged mitochondria, get rid of protein aggregates, liberate lipid from stores. This is this autophagy lysosomal defect, and it is found in all neurodegenerative disorders. And what's the evidence for it? Well, you see abnormalities in the membrane components that move vesicles from the autophagosome to the lysosome, and you also see accumulation of proteins. Those two findings, evidence of defects in that membrane trafficking and the consequences of that, accumulation of proteins in those cells, that is found for every major neurodegenerative disorder out there. Alzheimer's, Parkinson's, prion diseases, ALS and frontotemporal dementia, and Huntington's as well. They all have that shared problem. So that suggests a hypothesis, right? Where the rubber hits the road is if you correct the deficit, and do you get the rescue of the disease that you hope for? That's where it all comes down to, testing whether or not your hypothesis is valid. I would argue that the amyloid hypothesis has largely failed that test. But that is the test we have to implement on any new model that comes up, whether it's dietary intervention, effects on metabolism, or whatever. So I'm going to end with this. So this idea, as you can tell, I really care about. We've been working on it for a while. We have felt that that might be a central event. And so some years ago, we started evaluating what we thought was a potential disease target. And we wanted to know if that disease target could, in fact, suppress disease phenotypes in models of Alzheimer's and Parkinson's and ALS. And the answer to that is yes. And we've published that data. So that was about 8 years in the making. And then 2 years ago, we decided to try and find small molecules that would target components of this target pathway that I've described. And the good news is, and this is in part from help with the Huck Institute's structural biology skill set and people, we were able to do some computational searches for lead molecules that affected a target, and we got them. And we've started evaluating those molecules in a number of different models. And we've been able to show that those molecules do what we anticipate. They activate autophagy, and we started moving them away from models that we look at in either human cells, not iPSC cells, not stem cell derived ones, but we've expanded into a model we think is really important, namely stem cell derived models of these disorders. And my collaborator in San Francisco, Eric Ulian, has unbelievably terrific models using stem cells for ALS and frontotemporal dementia and for Parkinson's. So this past summer, literally, we began testing some of the small molecules we got from that. And the startling and incredibly encouraging result is that we suppress disease phenotypes in all of those models. So it's early days for us, but we have findings that are frankly beyond what I could have ever hoped for. And to make a long story short, I'm hoping it's going to be short. Our objective now is to license this technology to some people who've been supporting the work already. And our goal is to put the derivatives of these molecules, that is, ones that we modify and hopefully work a little bit better, we're going to try and get them into human phase 1 clinical trials in 2 years. It's ambitious, but maybe if we shoot for 2 years, we'll get it done in 3. Anyway, that's what we're trying to do. But I think any hypothesis that anyone has about Alzheimer's, it has to pass that scrutiny? When you manipulate it in a way where you show you have, does it make people better? So I'm just going to quickly acknowledge the fantastic people I've had the good fortune to recruit to my lab. Many of them undergraduates who have come in and they work during the summers full time, and then they work 20 hours a week during the school year. This Corinne Field on the left and Brianna, they've done a lot of our ALS work. The old guy in the middle is me, of course. Megan Pike to my left did all the beautiful iPSC experiments in San Francisco. Anusha Mondru is doing a lot of our cell culture work here at Penn State. And then I have great collaborators here at Penn State, Melanie on the metabolomic side, and at University of Georgia, Dr. Weiss, who's an expert in our field, and then at UCSF, Dr. Ulian, who's a model of neurodegenerative disease expert. So with that, I will close, and I'd be happy to, I guess we'll answer questions at the end. Anyway, whatever the format is, that's all I have to say. Thank you.
Thank you very much, Dr. Selick. This is really, really promising, amazing. I see Corina is saying very promising work, Scott. Congrats. Awesome. I really hope that people will consider putting questions in as we have Rollin starting her presentation. We're a little bit behind, but I will still like to introduce Rollin to the community to make sure that people know her. She's an amazing person based on the information we got and the interactions we had so far. So just in brief, Dr. Rollin Wright is an associate professor of medicine at Penn State Health Hershey Medical Center. She has clinical experience in geriatric primary care, post-acute and long-term care, pulse and geriatric trauma, dementia care across healthcare settings, and telemedicine. In 2020, she worked with older adult patients in the dementia care consultation clinic, where she piloted a process and workflow to do Medicare cognitive assessment and care planning visits with the goal of improving feasibility and delivery of comprehensive dementia care in primary care practices. Dr. Wright has extensive experience as a clinical educator, specifically in curriculum development, education scholarship, multiple modalities of teaching, mentorship, and clinical precepting for all learner levels in medical education. And she developed as well curricula for practicing physicians and physician trainees in the area of dementia care, interprofessional education, and post-acute and long-term care. Prior to being at Penn State, she was an assistant professor of medicine at University of Pittsburgh. Rollin, the floor is yours.
Thank you so much. This is a great opportunity. Really happy to be participating in this group. So I was tasked with kind of bringing everybody up to speed into the current state of affairs about what's happening on the clinical side of Alzheimer's dementia, so Alzheimer's and other related dementias. So you just got an amazing overview of what's happening at the cellular and molecular level in Alzheimer's disease, even a little taste of how that's translating into treatments. And so flipping it around and looking at it differently, what are we doing and how are we helping people who are actually living with this disease? How does this disease express itself? What are some of the symptoms that are particularly troubling? And are we, as a primary care workforce, really leaning into doing the best for our patients by identifying dementia and dementia risk factors early? So I'm going to leave that question to linger for just a few moments. All right, let's see if I can advance here. All right, so learning objectives for my very brief 15-minute whirlwind tour are 3. Actually, I'll probably pack in a few more there than are listed. Number 1, to describe the diagnostic criteria for Alzheimer's disease and other related dementias to differentiate the different families of dementias, because you know what? You wouldn't know it, but Alzheimer's disease is not the only type of dementia, and that's not the only proteinopathy happening in the brain. So differentiate the different families of dementias clinically and pathologically, and how do we diagnose what type of dementia we think the person in front of us has, and then to review the staging of dementia and why it matters. All right, so as Scott mentioned, there have been some super game-changing developments in the last couple of years. And these
Roland,
are,
one
yep.
quick, you're in the notes in the presenter, if you could put in the presenter mode.
Oh, let's see. I am not sure I can see it, how to do that.
Not you can, you should be
So,
able to go to one of the lower panels side.
yep.
Don't have the control and try one of those. Maybe the next one. Still presenter mode.
Yep.
If not, no problem, but we wanted to make sure, especially if you have.
So it says hide presenter view. You know what? I think I see what's going on. I'm going to stop sharing and then restart.
Probably better, yeah.
Okay.
And in the meantime, I see a question we can take maybe just briefly, if Scott can address it briefly. From Gustavo. Does your molecule enhance proteasomal activity or aggregates removed? Only if you can cover it briefly. If not, we can address it at the end.
I mean, I sent out a message to him. Yeah, the answer is we haven't tested proteasome activity. We've tested a lot of autophagosome to lysosome, and it definitely increases flux. One of my colleagues have shown changes in cellular aggregates of synuclein fibrils, but we haven't tested it in some of the other models. So lots yet to do.
Awesome. Thank you very much. Roland, don't worry. We can continue like this.
Sorry about that.
Okay.
It's yeah, not sure how to fix it at this point.
Okay.
So I know it's distracting. I'm sorry. Um, so just thinking about the game-changing developments in what's happening with Alzheimer's disease really should be translating into the clinical setting. Is it doing that? Are we keeping up? Are we in the clinical setting keeping up with what's happening on the forefront of diagnosing and managing this disease? So just a quick little overview of exactly what is dementia. I know we just talked about Alzheimer's disease and Alzheimer's disease pathology, but that doesn't really tell you very much about what is happening to the person who has the disease. So so dementia really is a brain disease. Neurons are damaged and they die by various mechanisms. It's a slow decline. It's a syndrome. So dementia isn't actually the disease itself. It is a manifestation of the symptoms of the disease. And it affects all aspects of cognition and life, including memory, learning, where a person who has dementia cannot learn new information. It interferes with their thinking, their reasoning, their problem solving, and definitely with their language skills, their ability to put their thoughts into words and understand the word and interpret the words that they are hearing. It also affects personality, motivation, interest in other people and surroundings. What are the undeniable truths about dementia? And these still hold true today, maybe for not too much longer, but these are the undeniable truths about this disease, that there is no way to prevent it. There is no cure. We do not have an effective medicine to treat its symptoms. We don't have a way to slow it down. The people who have dementia depend on others for every single basic need. And that behavioral symptoms are linked to dementia in almost 100% of people who have dementia. And that ultimately this is a fatal or terminal diagnosis. So the diagnosis of dementia, how do we diagnose dementia? And well, should we? I mean, if we don't really have a cure for it, and is there really anything we can do? Should we be screening for it? And many years ago, the U.S. Preventive Services Task Force came out and said, you know what? There's just not a whole lot of value in screening for that disease because there isn't a cure. And so for years, their recommendations have been to not screen for cognitive impairment. And with that, the culture that we're all growing up in when we go through medical training, that means that screening is really rare because somebody has said that there's not a lot of value in it. The symptoms or complaints of people who have cognitive difficulty usually present kind of vaguely, benignly, I'm having a little bit of difficulty, doing the bills when it used to be so much easier. I'm having trouble remembering things that people tell me, and I find myself I'm told that I'm repeating myself. Doing my daily activities, it's just getting harder to get motivated to do that. I'm just not picking up stuff as much as I used to. I don't even gone through the mail in the last couple of weeks. And the symptoms can either be reported by the person who is experiencing cognitive change, but most often it is by a collateral informant, the person who is witnessing the cognitive changes unfold and manifest. Right now, the diagnosis of dementia is primarily clinical. What does that mean? That means to get a clinical diagnosis of dementia, and this isn't just Alzheimer's, this is all comers, all types of dementia. It is a combination of three things: the presence of behavioral impairment, and that's in most people, but not all, measurable cognitive impairment, and then definitive witnessed objective functional impairment. And we'll come a little bit more back to that later. So the sensitivity of a clinical diagnosis, which is asking a few questionnaires, getting a little bit of data clinically from the person in front of you. You note that I'm saying I am talking about a diagnosis without an MRI, a diagnosis without a blood test. That has been the only way that we can diagnose dementia for many, many years. The sensitivity of a clinical diagnosis, the clinical picture in front of me and the history that I've gathered, the sensitivity is anywhere from 71 to 87%. Specificity, whereupon a brain autopsy might have been done afterwards to confirm the original diagnosis, the specificity is 44 to 71%. Who diagnoses dementia? Well, this is a really great question. I would like to know who diagnoses dementia, because what's happening is that dementia gets a bye week at most office visits with PCPs. PCPs, I have to be honest, in medical school, we receive very little training in how to screen for, diagnose, and then manage dementia symptoms. We get almost no training in how to do this. And medical students are not hanging out in cognitive disorders clinics. Let me just say that. So we have this disease that's so highly prevalent late in life, but yet so few clinicians really know what they're looking at when they see it. So the real memory experts out there are going to be your neurologists who are trained in cognitive disorders, neuropsychologists who are doing all sorts of cognitive function testing, and then geriatricians. And I would say that right now across the country, they're having as much trouble drumming up cognitive disorder specialists in neurology as they are geriatricians. And so there's not enough of us all to go around to help people with this disease. I want to talk just a moment about mild behavioral impairment. This is kind of a new element of carrying a diagnosis of dementia over the last few years. It is really what neuropsychiatric symptoms, these are maybe they're kind of soft symptoms in the very beginning, thought to be maybe a mood disorder. So these are neuropsychiatric symptoms like delusions, apathy, anxiety, motor disturbances. There are changes in personality and behavior, and they can be subtle. They appear after the age of 50, often before cognitive decline. Before there's measurable cognitive decline, somebody's changing. For neuropsychiatric symptoms, mild behavioral impairment, it's present in 97% of people who have dementia. So if you don't have it before you develop dementia, you're probably going to develop behavioral symptoms during dementia. And we've done a whole lot of work with our group in recognizing, managing non-pharmacologically these symptoms, but that's another talk for another day. Mild behavioral impairment is actually a precursor to dementia, often mistaken for plain Jane depression or anxiety, and called pseudo dementia early on. If it persists for more than 6 months, then it's legit mild behavioral impairment, a precursor to dementia. The 5 domains of behaviors are decreased motivation, like apathy, emotional dysregulation, impulse discontrol, social inappropriateness, abnormal perception or thought content, that's like hallucinations and delusions. It means if you, like, the worse the symptoms are, the more severe the symptoms are, the more it portends that the more rapid the progression of cognitive decline will be, the higher the rate of institutionalization, because these behaviors are really, really difficult to manage. Worse care partner stress, worse care, quality of life, not only for the person with dementia, but also for the care partner. Dementias are grouped into several main categories or families of dementias, and there's a different proteinopathy for each of these different types of dementia. And so we just got a brief clinic in Alzheimer's type dementia, which is primarily characterized by beta amyloid, phosphorylated tau protein abnormalities. Vascular dementia is a variety of pathology going on related to vascular disease in the brain, kind of like that lipid metabolism issue or that glucose metabolism issue that we're starting to know more about in the brain, and how it affects blood vessels and delivery of oxygen and glucose to the brain. Lewy bodies, a different type of proteinopathy, frontotemporal degeneration, and really, here's one reason why the single bullet theory for a biological to help with reducing or walking back the progression of dementia. One of the reasons that it might not work so great is because most dementias are actually mixed pathology. It's not just one pathology, it's multiple. And then there's this one last little family that we'll talk about in a couple of slides called late, which is kind of a newcomer to the field of different dementia pathologies. So biomarkers have really come of age in the last several years. Scott talked with you about several of them. And so what does that mean for the clinical picture? Well, it used to be that you had a biomarker, like you had evidence of atrophy of the brain on an MRI, but maybe somebody was normal cognitive functioning, kind of like what Scott was saying. Like, just because you have the biomarker doesn't always mean that you have the clinical manifestations of the disease. Um, so the diagnostic criteria for Alzheimer's disease are actually changing because of these biomarkers. So it used to be we really couldn't definitively link the biomarker to the actual disease. Now those two endpoints are coming closer together. For many, many years, you had to have the clinical picture, a clinical diagnosis, plus or minus neuropathology. That was in the very beginning. So it was a best clinical guess, which is still kind of what we're doing. And then it transitioned to where it's kind of diverged right around 2007 into two theories or two schools of thought about how to diagnose dementia. And the International Working Group really thinks that the diagnosis of dementia is, to Scott's, giving a nod to Scott's earlier point, was that, listen, if you don't have the clinical manifestations of the disease, you don't have the disease. And so the International Work Group has stood its ground and said, listen, you have to have both clinical and biological pathological evidence in order to get a diagnosis. And it emphasizes, they're emphasizing symptom and syndromal kind of approach to the disease. The Alzheimer's Association and National Institutes of Aging, on the other hand, have really taken a sharp turn into calling the presence of the biomarkers as having the disease. And they say, listen, for cancer, if you have cancer cells, you have cancer, even if it's in the earliest stages before it's actually clinically manifested itself. So we're going to go that route. And there was a big debate at the national conference on which school of thought was the proper or the right thinking school of thought. And in the debate on stage, it was the cards were totally stacked against the IWG. The Alzheimer's Association really pushed through and in a very convincing way that if you got the biomarker, you're going to have then you have the disease. It may just not be apparent yet. So when does the disease manifest? When there are symptoms, when the damage is already evident, or when there are clues that that damage is happening and it might accumulate enough damage to actually become like a clinical syndrome. So the biomarkers right now, they help us improve the accuracy of our diagnosis so that we can maybe move away from a clinical best guess, back it up with a biomarker. And, I saw somebody that I thought for sure might have FTD ALS, got a blood test, and no, it's beta amyloid. It's Alzheimer's disease that is really causing this weird array of symptoms, maybe some other things as well. So the biomarkers are eventually going to become the treatment targets, and that's one of the important. That is why they are so important today. So when the pathology is present, the disease exists. That's what the Alzheimer's Association would have you say. And these are the biomarkers under core 1. These are the biomarkers that appear early in the disease, long before the first symptom. And just wanted to show you what are these biomarkers, sort of looking in aggregate, what are they? That's what they look like. The differential diagnosis of different types of dementia or Alzheimer's disease is really kind of a conundrum. Like, what do we do as primary care physicians? Do we start testing 30 and 40-year-olds to see if they're starting to have the presence of these biomarkers? What kind of conversations should we be having? If they do have biomarkers, is there anything that that suggests if they have beta amyloid, or eventually we'll have biomarkers for more serum biomarkers for all of the different dementias, I suppose. But like, what kind of conversations should we be having? Should we be leaning into dementia prevention? Remember, dementia, not the disease, the syndrome. Is there a way, like, if you've got some biomarkers that are showing up in your blood, say about age 45, are there things that you can do to maybe suppress or mitigate the production of those biomarkers? If you got started early enough, could you do that? And could you prevent yourself from ever getting dementia? And that is a new field in neurology, is preventive neurology right now. Something to think about. Right now, this conundrum only applies to Alzheimer's dementia. And guess what? Not everybody has Alzheimer's disease or Alzheimer's dementia. Does the same principle apply to to dementia due to other neuropathologies? For example, if you have atherosclerotic neck arteries, does that mean, or your cerebral arteries are kind of gummed up with a little atherosclerosis, does that mean that you have the precursor to vascular dementia? I don't know if we're willing to go that far. So again, what are the implications for primary care and conversations in primary care? I'm not going to go through this whole slide. This is mostly for people's reference, but it is looking at the different types, different big families of dementias, what's happening in the brain, how does it express itself, and what are the biomarkers to date that we have. So I think that's kind of interesting, and I think that primary care clinicians need this table to help guide them when they have a person in front of them who's starting to have the first symptoms. Question, is Alzheimer's disease preventable? Well, Scott talked about, he was kind of alluding to maybe it was. There have been a couple of really interesting studies that should really be primers for primary care physicians who want to start to help their patients prevent getting this disease. It's easy to identify who's got the highest risk of getting the disease. So in the Lancet, in a Lancet article or a compendium back in 2024. They've been looking at this for years, and they've been trying to pinpoint for each of these risk factors, how much does it contribute to the risk of developing dementia. So it's kind of small, but what you can see is that having cognitive reserve, early in life, higher education, higher level intelligence, more resources, more cognitive reserve, has a protective effect to an amount of about 5%. And then here are all of these other little modifiable risk factors. And I say little, but the cumulative effect, if you were to nail hearing loss and get that ironed out, if you were able to lower cholesterol, treat depression, manage or prevent traumatic brain injury, stop smoking, if you did all of these things, you could reduce your risk of developing dementia by 45%. And that's what it says down here in a very little circle, which needs to be a bigger circle, honestly. And so how would you go about doing that? And that, to me, is good primary care. And this is where the primary care piece comes in. We need to be doing a checkup from the neck up for everybody over the age of 65 and anyone who has been exposed to any kind of noxious brain event. And so here are all of the things that we can do to try to prevent dementia. And I bet that there is a cumulative benefit if you mitigate this cumulative risk. So you know, the other big thing, the other big reveal at the Alzheimer's Association International Conference, and I'm just seeing the time, and I'm so sorry. I'll speed it up and move on right after this slide. So was the U.S. Pointer study, which put into place all of those things that may affect glucose metabolism in the highest risk patients in the brain. And the combination of the intervention was a combined intervention of physical activity regimen and not just walking. Let me just say it wasn't just walking a mile or 3 miles a day. It was moderate intensity physical activity for a minimum of 12 minutes a day. The MIND diet, strict adherence to the MIND diet, and a cognitive activity. They were able to show that in these high risk patients, over 2,000 in this randomized controlled trial, or randomized trial, this was that they improved their own cognitive performance. They didn't have dementia yet. And in a study that was released last year, Dean Ornish released it from his group. He looked at people who already had mild cognitive impairment or mild dementia, put into place an even stricter lifestyle intervention, and was able to show that that at least a third of the folks in the intervention arm were actually demonstrated improved cognition and near elimination of beta amyloid from their plasma. Staging matters. That was my last major point, and I have that here to say that that right now the Alzheimer's Association model would have us diagnosing people as having Alzheimer's disease, stage 1 Alzheimer's disease, if they had no cognitive impairment, but they did have a core1 biomarker. And then the progression of the disease really is with the accumulation of deficits. You kind of cross the threshold from mild cognitive impairment to dementia when you have that functional impairment, when you're having difficulty managing your bills, you're making some mistakes while driving, you're overall more inefficient. Most dementia is not diagnosed until stage 5, after the horse is well out of the barn. And here are the opportunities for interventions, whether it's lifestyle changes or brand new medications. Implications are, what are we going to do in primary care with these biomarkers? How might we lean harder on patients to help them reduce their risk factor for having dementia, for developing dementia, and what other potential biomarker and drug targets might there be in other dementias? Because again, Alzheimer's is not the only one. So there have been tremendous developments in the last couple of years that could revolutionize how we approach primary care and secondary care of this disease. It's time for more dedicated research effort toward the other dementias, and the most clinical presentations of dementia are probably due to mixed pathology and multiple modifiable risk factors, and that may compel at-risk older people to make these powerful lifestyle changes.
Thank you, Roland. This was a really good summary. And actually, both of these talks have been inspirational. There's so many questions, but fortunately, we have such broad expertise, including the people in our audience. I've been looking around, it's amazing. All these people can contribute in our audience, can contribute to solving, to at least trying to solve this big issue, this big problem. So, the two speakers today, thank you very much. The topics were very, very complex, and it was difficult to cover them within an hour, which means that we're strongly encouraging everybody to follow up with both Scott and Roland if you're interested in additional conversations, as we don't have time for additional questions, but also thanks, Scott, for addressing the questions that have been shared in the chat. We had some really good comments there that we can, from Glenn in particular. Thank you so much for sharing your thoughts. So we would like to make sure that we're sharing also what's next on this series. We're going to follow up with the next topic in the next month. October 30th, we're going to cover neuroimaging capabilities. And we have 2 other amazing speakers. So we really hope that you're going to join us. And we're going to try to continue to bring to you every month an interesting topic and interesting speakers. And we're inviting you to also express interest in becoming speakers of this series. So with this, thank you very much.